Okay. Usually it tells me to click, but it doesn't. So here we go. So for those who haven't attended before, don't know me, I'm Rhea Markowitz. I'm from the Georgia Cancer Center, and I'm part of the hub team of our TeleDerm project. Dr. Patton couldn't be here today, to help co-facilitate, so I'll be doing it alone with Brenda and Kenza, of course, by my side, figuratively, not literally. So I want to ask everyone to put their screens on gallery view and try and keep your camera on if you have the bandwidth so that we can see each other. So let's see. Next slide is the TeleDerm website. I know I keep reminding you about the Teledermatology Serving Georgia website that has a lot of good information on it. If you, there are training videos that you can watch for CME credit if you follow the directions correctly. And we have links to past TeleECHO sessions, and there are things to read, so to catch up on dermatology or dermoscopy. Lots of good information there. So let's welcome our participants today. We may have a smaller group than usual because of the little golf tournament that's starting here today in Augusta. So many people are off, although we have people like Dr. Davis, who is tuning in from her week off, her vacation. So we have our PCPs from the East Georgia Healthcare Centers who are participants in the clinical arm of Teledermatology Serving Georgia. So we welcome you here, and there may be PCPs from other rural clinics. Hopefully we have some of the family medicine residents from MCG, although some of them may be off on break as well. And we have for dermatologists, I already introduced Dr. Davis. We have Dr. Harold Rabinovitz, and Dr. Buchanan is on, but I don't think she's going to be talking much. So there may be some MCG medical students here, and of course Brenda Santiano and Kenza Mamuni, who are running the controls here with me. We could not do these without those two people. And anyone, if you're attending for the first time, we welcome you and hope that you will continue to join us for our TeleECHO sessions. So I think that people are putting their names and affiliations and so forth in the chat. If you have not, please do that, following the example of others. We do need to keep records of who's attending, of who's here. And so to go over today's agenda, we're doing our introduction. Our didactic presentation will be by Dr. Sally Young, who's a PGY3 resident in the dermatology department at MCG, and she will give the presentation, and then we will have a case presentation from Christy Taylor, who's an MS3 student at Medical College of Georgia and the Athens campus, and also she is a dual degree medical student, and is currently at the Duke University campus finishing up her master's in clinical informatics. So I don't think we've ever had any student from the Athens partnership present, and we haven't had any student from the dual degree program present. So this is a first. And then we'll have a wrap up a discussion and wrap up, and then announcements. So at this time, I'm usually introducing Dr. Patton, but as I said, he's not here, so I'll introduce myself again, and I'll do his bit talking about Project ECHO. So next slide. So here we are, part of Project ECHO, which is known for moving knowledge instead of people. And next, Project ECHO uses telemedicine, in our case, teledermoscopy and teledermatology, and distance learning to dissolve the dermatologic health disparities faced by people living in rural areas in the state of Georgia and elsewhere. Next. And we've already announced that we are recording our sessions, and by attending and listening in, you are consenting to be recorded. Want to remind people not to mention any PHI in our discussions, and the final slide will have the information about obtaining CME credit. And if you have any problems with the or any questions, you can email us at teledermatology@augusta.edu. Next. And Project ECHO collects data about participation, questions, and so forth in the TeleECHO programs, and this data is kept confidential. Next. And if you will keep your microphones muted when you're not speaking, but remember to unmute them when you do speak. And if you have questions, you can type them into the chat. You can raise your electronic hand, or you can speak up. We do ask that you introduce yourself and tell us what your affiliation is, where you are from. And as I mentioned before, try and keep your camera on if you have the bandwidth to do it. And if you have technical problems, you can write them in the chat or email Kenza at kmamooney@augusta.edu. So next, it's my pleasure to introduce Sally Jung, who's a derm resident. Dr. Jung has spoken with us before, and she will be speaking to us today on scarring alopecia. So, Dr. Jung, if you can.
All right, let me just share my screen. Okay, are y'all able to see my screen?
Yes.
Okay, so my name's Sally. Thank you for the introduction. I am a second-year dermatology resident at the Medical College of Georgia, and today I'm going to present on scarring alopecia. A couple of sessions ago, I presented on non-scarring alopecia, and alopecia is a pretty dense topic, so we decided to kind of split the two. So today we will finish up with scarring alopecia. So, with scarring alopecia or cicatricial alopecia, this occurs when the follicular epithelium is replaced by fibrotic tissue, leading to irreversible hair loss. There are primary and secondary cicatricial alopecias. With primary cicatricial alopecia, the hair follicle is destroyed by an inflammatory process that targets the follicular unit, such as lichen planopilaris or LPP, discoid lupus, and central centrifugal cicatricial alopecia or CCCA. Secondary cicatricial alopecia is secondary to another inflammatory process, and the follicle is an innocent bystander. And this typically occurs due to like permanent hair loss from radiation, deep burns, cutaneous malignancies, and chronic infection. It can be difficult to diagnose scarring alopecia, especially during the early stages when signs and symptoms are subtle, and dermoscopy can be a pretty helpful and easy tool to guide with diagnosis, and we'll go over some of the hallmark dermoscopy findings today. But UV fluorescence can also be helpful with scalp diseases. I talked about this during my last lecture on non-scarring alopecia, but just as a reminder, I'll go over it again. And UV fluorescence can be helpful in determining scarring versus non-scarring alopecia. So in non-scarring alopecias, the follicular epithelium is intact with preservation of the sebaceous glands. And with the UV fluorescence, you'll be able to see pink, red, or green fluorescence, which reflects coproporphyrin 3 produced by C. acne and presence of malassezia in the sebaceous glands. So in the top row, you can see that bright red, pink, and green fluorescence, which means that the sebaceous glands are preserved. While with scarring alopecias, that sebaceous gland is not preserved due to the fibrotic tissue, so you won't be able to see that fluorescence. So this can be a really easy tool to determine non-scarring and then scarring, and then go down your differential for the two different types of alopecias. Scalp biopsies are also another great diagnostic tool and really the gold standard for diagnosing scarring alopecias. It's pretty straightforward. What we'll do is we'll numb up the area with lidocaine and epinephrine and then use a 4 mm punch extending into the fat. We like to take the biopsies from an area of inflammation with residual hair, and ideally 2 biopsies should be performed, one for vertical sectioning and the other for horizontal sectioning. And here on the very right, you can see the differences between the sectionings. And this just allows the pathologist to have a more comprehensive look at the scalp to determine the best diagnosis. With that being said, it's really important to let your pathologist know that you did take 2 different tissue samples for different sectioning so that they can process it in the correct way. After the tissue is removed, we typically use gel foam for hemostasis, but you can also suture. It's important to note that the biopsy will be left with a small permanent scar where the hair will not grow back unless it is sutured back together. And typically we don't worry about this as much because we're biopsying an area with alopecia, but it's something to keep in mind when discussing the procedure with patients and counseling them on the results. And today, I'm going to mainly focus on the clinical features of various scarring alopecia. I think for primary care providers, it's really important to help us with early detection of the disease and refer to dermatology to prevent any further irreversible hair loss. And there are also some treatments that primary care providers can implement while patients await their dermatology appointment. And I'll just briefly go over those. And the goal of treatment with scarring alopecia is to reduce any inflammation and prevent further follicular destruction rather than regrowing the lost hair. This is an excellent overview of scarring alopecias from a paper in JAD, and I will go over each one of these along with folliculitis, decalvans, and sarcoidosis, because these are the most common scarring alopecias that we see in clinic. So starting with CCCA, or central centrifugal cicatricial alopecia. So CCCA predominantly affects Black women. It typically starts with a single patch of hair loss at the vertex of the scalp, and as the name suggests, the hair loss expands in a centrifugal and symmetric pattern. There are also some unusual variants that have been described with irregular patches of hair loss. You may see some follicular papule scaling area and erythema, but this is quite rare. And then the scalp can have some burning and pruritus associated with it. As you can see in the photos, the hair loss can be quite extensive, and oftentimes the disease will progress and the scalp will be left with shiny scarred plaques. On dermoscopy, you may be able to see perifollicular dark gray halos, and you may also be able to see these pinpoint white dots. The pinpoint white dots can be a normal scalp feature of Black patients, but in CCCA, the white dots will be numerous and usually interspersed within the scarring. And the scarring often looks like these white patches that interrupt the regular honeycomb pigmented network on the right. You may also see some isolated tufts of hair or numerous hair from a single follicle and perifollicular pustules, which aren't appreciated in these photos. The exact pathogenesis of CCCA is unknown, but it is likely multifactorial with a genetic component. They have identified a genetic mutation, PADI3, to be associated with CCCA, and there are also known triggers such as hairstyling practices, infections, autoimmune disease, and diabetes that may trigger or worsen CCCA. And there are many different ways to treat CCCA, starting with healthy hair practices. Because hairstyling practices can trigger CCCA, I think it's really important to counsel all of our patients on these practices. And this is a really helpful chart from Bologna, which is our dermatology textbook, and I found this chart to be really helpful to counsel patients on. There are simple things that patients can incorporate to ensure that their hair is healthy to prevent any further hair loss. And then other treatments include corticosteroids, topical calcineurin inhibitors, and systemic therapy to reduce the inflammation. Our go-to is doxycycline, 100 milligrams twice a day, but you can see that there are other options out there. And then you can always add minoxidil, topical or systemic, to promote hair growth of the hair that's still healthy and growing. Now we will talk about frontal fibrosing alopecia, or FFA, and lichen planopilaris, or LPP. And I grouped these together because they can have very similar features. And FFA and LPP are considered to be within a broader lichen planopilaris spectrum. So you'll see that a lot of the features overlap and the treatments also overlap. So with FFA, this predominantly occurs in perimenopausal women, but younger women and men can be affected as well. It typically presents with recession of the frontotemporal line, but it can involve the occipital and retroauricular hairline as well. Other clinical features of FFA include lateral or complete eyebrow loss, partial loss of eyelashes, and thinning of axillary, pubic, limb, and truncal hair. So it's really important to ask patients about hair growth in other areas of the body with typical terminal hair growth to see if they have involvement there as well. Pathophysiology is thought to be due to an immune-mediated inflammatory attack on the bulge region of the hair follicle. And then inciting factors that lead to this inflammation is unknown, but some environmental exposures such as leave-on cosmetics, facial sunscreen, fragrances, hair care products, and more have been identified as potential triggers. Dermoscopy features of FFA include absence of follicular opening, cicatricial white patches, blue-gray dots, perifollicular erythema, perifollicular scaling, and lonely hairs. And in these photos, you can see the loss of the follicular openings, erythema, perifollicular scaling, and some lonely hairs as well. Treatment can be challenging, but first line includes hydroxychloroquine, doxycycline, and corticosteroids, with intralesional being the first choice, and then oral for very severe cases. And then adjuvant therapy includes topical potent steroids, calcineurin inhibitors, minoxidil, and 5-alpha reductase inhibitors like finasteride. And there is literature on the use of other systemic drugs like retinoids, mycophenolate, methotrexate, cyclosporin, JAK inhibitors, apremilast, and pioglitazone as well. Moving on to LPP, and here you can see that the distribution is different from FFA. LPP typically presents in white women between 40 and 60 years of age. It is very rare in children, and it typically starts with one or more small patches of cicatricial alopecia on the vertex or occipital scalp, and you can often see perifollicular erythema and hyperkeratosis. Over time, the patches of alopecia can increase in size and become confluent. Similar to FFA, you may be able to see some lonely hairs in the central portion of the alopecia patches as well. Burning sensation, pain, or pruritus is usually associated with active disease. And the pathophysiology is very similar to FFA, where it's an immune-mediated response to the bulge region of the hair follicle. LPP in particular is a variant of lichen planus, and up to 15% of patients may have coexisting mucosal LP, so it is important to ask patients about oral and other mucosal site symptoms as well. Dermoscopy is pretty similar to FFA, where you'll see perifollicular erythema and scaling. You may also see some elongated blood vessels as well, and in late-stage disease, you'll be able to appreciate milky red areas with no follicular openings. Therapy is similar to FFA. You have your first line with hydroxychloroquine, doxycycline, and then steroids, and then adjuvant therapy with the topical steroids, calcineurin inhibitors, minoxidil, and 5-alpha reductase inhibitors. And then again, we do have some options as second line as well. We'll now talk about discoid lupus. So discoid lupus can be an isolated disease with only cutaneous findings, or it can occur in the setting of systemic lupus. It typically affects women in their second to fourth decade of life, and Black patients with discoid may be at risk for more severe disease. So patients with skin disease only typically have lesions on their head and neck, including their scalp, and it typically starts with erythematous or violaceous papules or plaques with scaling and dilated plugged follicles. And then chronic inflammation leads to central hypopigmentation with atrophy and peripheral hyperpigmentation, which is commonly seen in individuals with darker skin phototypes. On the scalp, you can see the inflammatory lesions at first, which will develop into the cicatricial alopecia. As you can see, it can be pretty limited to kind of smaller areas on the scalp, but it can also be pretty progressive and extensive and can affect other parts of the head and neck as well. These lesions can be associated with pruritus, tenderness, and burning. On dermoscopy, discoid of the scalp can show large yellow dots, thick arborizing vessels, and fine scaling. And then in late stage disease, you'll have features similar to other cicatricial processes, such as milky red or white areas with no follicular opening. Besides the scalp, discoid likes to show up on the ears, so we always like to check the conchal bolt to see if there is any involvement, but it can also affect the face and even trunk and extremities. And you can see that even when it is not on the scalp, it has that similar erythematous violaceous look that progresses to atrophy with hypo and hyperpigmentation. Again, discoid can be an isolated disease or occur in the setting of systemic lupus, and a 20% likelihood of systemic lupus with generalized discoid, and then 5% with localized discoid. So it's really important to do a thorough workup if systemic lupus is on your differential along with discoid. So you should consider additional testing such as ANA, double-strand DNA, CMP, and UA to check for systemic disease, and then refer to rheumatology as needed. Discoid, like systemic lupus, can be highly photosensitive, so treatment starts with photoprotection. I think it's really important that we counsel patients on photoprotection because that's really going to prevent some of the severe flares they may have. And then other treatments include topical and intralesional steroids, hydroxychloroquine, and other medications. There are also some new monoclonal antibodies such as anifrolumab and then JAK inhibitors that have also been shown to be effective in discoid lupus. Next, we will talk about dissecting cellulitis. So dissecting cellulitis is most common in Black men. Lesions typically begin as firm nodules on the mid and posterior vertex scalp. These nodules are typically alopecic. Nodules may develop into boggy, fluctuant, interconnecting sinuses that drain purulent material. And then over time, the nodules can become fibrotic and result in a cicatricial alopecia. Dermoscopy will show yellow structureless areas, black dots, yellow dots, and dystrophic hair shafts. And you can sometimes see tufted hairs, which is when you'll have multiple hairs coming out of one follicle, such as the center photo there. Dissecting cellulitis is part of the follicular occlusion tetrad, so it can coexist with hidradenitis suppurativa, acne conglobata, and the pilonidal sinus or cyst. They're part of the tetrad because it's thought to be that all of these processes are due to follicular hyperkeratinization. So hidradenitis suppurativa, or HS, presents with recurrent inflammatory nodules and abscesses that will progress to sinus tracts and scars, typically in intertriginous areas. Acne conglobata also presents with these inflammatory nodules, abscesses, and sinuses, but this is usually on the face, neck, and trunk. And then pilonidal cyst typically presents with an inflamed cyst in the gluteal fold overlying the coccyx. I think this is important to note that this tetrad exists and patients may have overlapping features because this can help you treat something that they wouldn't have mentioned otherwise, but it can also help with the management of your dissecting cellulitis as well. Treatment starts with oral or intralesional steroids to help with the inflammation, and there are multiple systemic therapies such as isotretinoin or Accutane, antimicrobials like doxycycline, TNF inhibitors, other retinoids, dapsone, and colchicine that have all been shown to be effective in treating dissecting cellulitis. Next, we'll talk about acne keloidalis nuchae, or AKN. So with AKN, usually affects young Black men. It is significantly less common in white individuals, and it starts with papules with occasional pustules that typically affect the posterior neck and lower occipital scalp. The papules are typically smooth and firm, and over time, they can coalesce to form larger keloid-like alopecia plaques and kind of involve the entire posterior scalp and neck. The pathophysiology is unknown, but some Some triggers, such as chronic follicular occlusion or trauma due to friction, heat, humidity, hair cutting practices, autoimmunity, infection, and medications, have been found to be contributory. And the thought is that the triggers can lead to damage of the hair shaft, leading to agranulomatous inflammation and scarring. On dermoscopy, you may be able to see perifollicular pustules and a white halo surrounding the hair follicles, which corresponds to perifollicular fibrosis. And then in late stage disease, you may be able to see the tufted hairs that we also saw with dissecting cellulitis. Treatment includes avoiding possible triggers. Patients should avoid any headgear or clothes that may cause irritation to the posterior scalp and neck. And then you can also start with topical tretinoin and then a topical and/or intralesional steroids for the inflammation. Topical or systemic antibiotics used for acne can also be effective, such as doxycycline. And then ultimately, those keloids can be treated with surgical excision and lasers. And then overall, oral isotretinoin or Accutane has also been found to be pretty effective. Next, we'll talk about folliculitis decalvans. So folliculitis decalvans typically affects young and middle-aged adults, predominantly men, and presents with recurrent follicular pustules with perifollicular erythema, scaling, erosions, and hemorrhagic crust. These may progress into larger areas of cicatricial involvement. This is a neutrophilic primary cicatricial alopecia thought to be caused by an abnormal immune response to the follicular microbiome, leading to inflammation and permanent follicular damage. Dermoscopy will show these tufted hairs, again, multiple hairs from one follicle surrounded by perifollicular hyperplasia in a starburst pattern. For treatment, we typically start with steroids or topical calcineurin inhibitors, and then antibiotics can be used as well. We typically start with doxycycline, but there is some literature that suggests clindamycin and rifampin may be more effective. And then isotretinoin has also been shown to be effective as well. And there is low level of evidence for other treatments, but there are treatments out there. And then finally, we will talk about sarcoid. So scalp sarcoid is a rare manifestation of cutaneous sarcoid. And to give a little background about sarcoid, it is a multi-system disease of unknown origin that can involve virtually any organ system, including the skin. It can have different presentations on the scalp, including localized areas of cicatricial alopecia with scaling and erythema. It can also present with red, brown, purple papules that we typically see on the face, trunk, and extremities of cutaneous sarcoid. It can also mimic discoid lupus with areas of pigment change and atrophy. It can be limited to one area or pretty extensive. And as you can see, there is a wide variety of presentations for sarcoid of the scalp, and it can be difficult to diagnose clinically. Many patients with scalp involvement may have other cutaneous involvement as well. So a thorough cutaneous exam is indicated whenever the diagnosis is suspected, and it may also help you diagnose the scalp as well. So cutaneous sarcoid, similar to the scalp, can have various presentations. It can present with red, brown macules and papules on the face, typically on the nose and periorbital areas. You can see similar lesions on the trunk and extremities. They can sometimes present as plaques. And then patients with dark skin phenotypes may present with hypopigmented patches or plaques. You can also have these firm oval subcutaneous nodules on the trunk or extremities. And then sometimes sarcoid will present within tattoos, pre-existing scars, and prior sites of trauma. As you can see, sarcoid can really look like anything, and it is known to be a great mimicker or great imitator. But if your patients have, a scarring alopecia and some of these findings, it may cue you into a diagnosis of sarcoid, so it can be pretty helpful. Sarcoid, it's a granulomatous disease, and it's due to hyperactivity of the immune system. And there have been some triggers that have been identified, such as autoimmune disease, certain exposures, such as zirconium or talc, infections, and some medications. And a possible genetic component has also been identified as well. A helpful tool in identifying sarcoid is dioscopy. So dioscopy is when you take a glass slide, such as a microscope slide or your dermatoscope, and press firmly against the lesion. And this is typically used to help differentiate between vascular and non-vascular lesions, but it can also be helpful with sarcoid. And with sarcoid, the lesions will have like a yellow-brown or apple jelly look. And it's interesting because scalp sarcoid dermoscopy will demonstrate similar findings. And with the scalp, you'll see these yellow, brown, orange discoloration or globules. And you may also see prominent telangiectasia and dystrophic hairs as well. Again, sarcoid can be a multi-system disease. It most commonly affects the lungs, followed by the lymph nodes, eyes, heart, liver, spleen, central nervous system, and more. And when you have a patient with cutaneous sarcoid, it's really important to do a comprehensive workup with a good review of systems and get a CBC, CMP, chest X-ray, PFTs, and EKG, and refer out as needed. For treatment, we'll start with topical or intralesional steroids or systemic steroids for really severe cases. And there are other various systemic medications, including hydroxychloroquine, minocycline, doxycycline, TNF inhibitors, retinoids, and more. So that's the end of my presentation. And I know that we covered a lot of material today. And if anything, I've learned that scarring alopecia can be really difficult to diagnose and treat. And you can see that there is a wide variety of presentations and a lot of different treatments out there. But with this presentation, I just want to emphasize that, scarring alopecia is an irreversible hair loss that results from permanent follicular destruction. And clinical findings may be subtle, but early recognition is really essential. So if you have any suspicion, it's really important to consider a scalp biopsy and a dermatology referral. Some subtypes of scarring alopecia may have associated cutaneous and or systemic features, so it's really crucial to perform a thorough skin exam and review assistance as further workup may be indicated. And then lastly, again, treating scarring alopecia can be really difficult, and the goal of treatment is to calm down the inflammation, halt progression, and preserve the remaining hairs. And that's what we can help with. And yeah, so that's the end of my presentation. References.
Well, thank you, Dr. Jung. And we have one question already in the chat. Dr. Sheldon writes, if a patient comes in with discoid lupus, even with negative anti double-strand DNA, what other markers would be of concern that would be concerning for evolution into full-blown lupus?
I can answer that if you want. So, most of the time when we see discoid lupus, we do not do a systemic workup unless the review systems is positive. So if people have aphthous ulcers in their mouth and they have photosensitivity, may have malar rash, then we will draw an ANA as a screening and then get the double-stranded based on that. But if their review systems is totally negative and they just have DLE, then we usually do not do much of a workup at all. I don't. And I reassure them that that's not likely to be an issue.
Are there other comments, other questions?
And that was a great presentation. I might just make a couple comments. As Sally said, scarring alopecia, there's no going back. So you want to be aggressive early on. It's maybe just your hair, but that's really important to a lot of people. And some of these things are very painful and they hurt, they're tender. So I always offer my patients a biopsy early if I think it's, especially if it's CCCA or LPP or frontal fibrosing, because it's just important for people to have that option early, especially since some of our treatments don't bring back the hairs that are already lost. So if people want to try empiric therapy and it's not giving them their hair back and their expectation, then it's just nice to have offered that early on. A lot of patients don't want their scalp biopsied. It's really not that big a deal, but if they don't want their scalp biopsied, it's just nice to have offered that early on because it does help you direct your therapy. You're only as good as your dermatopathologist, though. So if you're going to do scalp biopsies, you've got to send that specimen to a dermatopathologist who understands hair. If you do 2 biopsies, one for horizontal and vertical sections, I usually put them in one bottle so that when they arrive at the lab, they wonder, why are there 2 in here? So they know that, then you put on the little note, one's for vertical and one's for horizontal section. If you send them in 2 different bottles, they're going to process them the same way. And you always call your pathologist ahead of time and say, I'm sending you specimens, hair biopsies, so that when it gets to the lab, they know what to do with them.
Okay, well, shall we move on to our case presentation? So we have Christy Taylor, who is our medical student, and she will, you can start sharing your screen.
Alrighty. Are you all able to see my presentation screen?
Yes.
Perfect. So hey everyone, I'm so glad I can share this patient story with you today from Dr. Buchanan's cases. So let's get right into it and see if you can guess this patient's diagnosis. A 76-year-old woman presented with gradual recession of her frontal hairline over a period of years. She also had itching and intermittent tenderness along her hairline and eyebrow thinning. Her past medical history was significant for urticaria and eczema treated with dupilumab. On physical exam, there was clear recession of the frontal and temporal hairline, which you can see here. Her hairline was sparse and thin, and if you look at her forehead wrinkles on the right, you can tell where her prior hairline was and how much recession she'd had from baseline. On closer examination, we see these lonely hairs at her hairline, which is an important clue for her diagnosis. For your reference, here's another patient with the same diagnosis that makes the lonely hair sign very clear. One more sign that was harder to see on this patient was erythema and inflammation at the hairline, which you often see in this diagnosis. So I've included a picture here. This is another patient, but you can clearly see the erythema and inflammation. And the reason we see this erythema is because of the ongoing inflammatory activity at the hairline. In contrast, the reason why we don't see erythema at her original hairline is because those areas are now inactive scars. Now let's take a moment to think. Based on this information, what's on your current differential? Here are some common pathologies you might be considering. If we look at which ones might show a recessing frontal hairline, we might consider frontal fibrosing alopecia or traction alopecia. However, this patient didn't have a history of wearing hairstyles that would put a lot of tension on her hair, like ponytails, braids, and extensions. We didn't see a fringe of baby hairs like we might expect with traction alopecia. Looking at the patterns, we would expect in the other diagnoses, female pattern hair loss, which will show central scalp thinning in a widened part rather than the frontal hairline recession we see in this patient. And we don't see the patchy hair loss you might expect in alopecia areata or the plaques in discoid lupus. Another way you might think about it is based on scarring versus non-scarring pattern. Seborrheic dermatitis, traction alopecia, and alopecia areata are all non-scarring. Only frontal fibrosing alopecia, discoid lupus, and occasionally advanced female pattern hair loss show a scarring hair loss pattern from this example differential you might have. So our next step to confirming the diagnosis is, does this patient have scarring or non-scarring hair loss? From a distance, the area looks smooth, shiny, erythematous at the edges, which makes scarring hair loss more likely. But let's take a closer look to confirm. Under dermoscopy, the first thing you might notice is that we clearly see decreased follicular density. Upon taking a closer look on the right, we see erythema around the hair follicles, a loss of follicular openings in scarred areas, and hyperkeratosis or scale around the hair follicles. This is a major diagnostic sign for scarring hair loss. Erythema and hyperkeratosis around the hair follicles means that there's active inflammation targeting the follicles. The loss of follicular openings means that the follicular unit has been destroyed and not just temporarily shut down. Now, when we turned the UV light on in the dermatoscope, we saw the image shown on the left. What do you notice? Notably, there's no red-orange fluorescence. And this is important because, as Sally mentioned, you might have heard of Cutibacterium. It's the main bacteria you hear about with acne. And this bacterium loves to colonize hair follicles and associated sebaceous glands. Cutibacterium generate their own porphyrins to help with its electron transport chain, and these porphyrins emit that red-orange light when UV light is shown on them. So on the right, you can see this image of a non-scarring alopecia areata with vibrant fluorescence taken from Dr. Buchanan's clinic at MCG. The lack of fluorescence in our patient gives us a good clue that her hair loss will not be reversible with treatment. This is another piece of the puzzle indicating that this patient has scarring alopecia. I wanted to draw your attention to the fact that sometimes fluorescence is more difficult to distinguish and can be quite subtle. Here's a quick slide showing a more difficult example with scarring alopecia on the left with the same diagnosis as our patient, and non-scarring alopecia areata on the right. You can see that the fluorescence in this case is more subtle. Now it's time to make our diagnosis. Given the key facts we know about the patient, she's a postmenopausal woman with gradual hairline recession. She has itching, tenderness, and redness along her hairline, along with eyebrow thinning and the dermoscopy findings that we mentioned. This is giving us a strong clinical picture for a subtype of lichen planopilaris called frontal fibrosing alopecia. Lichen planopilaris is a type of primary lymphocytic scarring alopecia, which just means the immune system causes inflammation around hair follicles, leading to permanent follicle destruction. Although there are many types of primary lymphocytic scarring alopecias, lichen planopilaris's name comes from its distinct pathology. Lichen plano refers to the band of lymphocytes the pathologist sees between the dermis and the epidermis. The top right picture shows the pathology slide of lichen planus. The pilaris part means those lymphocytes cluster around hair follicles, which you can see in the picture on the bottom right, showing lichen planopilaris. Although there are a few variants of lichen planopilaris, they are easy to distinguish clinically. We either have a patchy scalp in the classic form, the frontal recession in the frontal fibrosing form, or a patchy scalp plus axillary and pubic hair loss plus body papules in the last form. And to reiterate, the stereotypical case of frontal fibrosing alopecia is frontal hairline recession with eyebrow loss in postmenopausal women. The natural course is variable and unpredictable, with some cases stabilizing spontaneously, but treatment discontinuation is often associated with disease flare-ups. Although no standardized treatment guidelines exist, evidence for treatment comes from retrospective studies. The goal of treatment is to slow disease progression and suppress inflammation. This is a good reference slide showing the main treatment modalities used for FFA. On the top, we have common first-line treatments with systemic and procedural treatments shown on the bottom. In this case, the patient's FFA disease had been stable for years. She declined systemic therapy and elected for topical clobetasol only. The treatment you plan with your patient can be individualized and patient preference taken into account. For a general rule, if the patient has stable or mild disease and slow progression, you may consider topical calcineurin inhibitors and low to mid-potency topical steroids. For active disease, consider systemic hydroxychloroquine and potentially also topical calcineurin inhibitors and steroids. And for refractory or rapidly progressive disease, you may consider the other treatment modalities like 5-alpha reductase inhibitors, methotrexate, etc. One other thing I wanted to mention is for eyebrow involvement, intralesional triamcinolone showed good results. In conclusion, if you see a postmenopausal woman with frontal hairline recession, eyebrow thinning, and the findings we talked about in dermoscopy, think frontal fibrosing alopecia. It's important to recognize this early to prevent permanent scarring, and the goal of treatment is to slow progression and suppress inflammation. Thank you so much for listening to this presentation today. I hope you had as much fun learning about frontal fibrosing alopecia and the other scarring alopecias that Sally talked about as much as I did, and I hope you feel more prepared if a patient like this comes into your clinic. Thank you.
Thank you so much. Questions? Great presentation. Questions? Anything in the chat? Any more comments? So how frequently do you see any cases of any of these cases, I guess, in the clinic? Are they common?
Yeah, I was going to say, we definitely see scarring alopecia every week in the clinic, and CCCA, especially in Black women, is extremely common and can be progressive. That's probably the most common of the scarring alopecias I think that we see. I don't know if Sally, you'd agree with that, but we see a lot of CCCA. And sometimes it's hard to tell the difference between that and LPP on biopsy, but clinically are different demographic. So it's real and it's progressive, and we like to jump on these things early. I always tell people if the scalp is burning or tender, there's inflammation there and it needs to be addressed. And the other thing I will say too is that we see a lot of multifactorial hair loss. So a lot of these people will also have inherited pattern thinning. So you can actually have both. Sometimes you inherit female patterned hair thinning and you have one of these. And that's why minoxidil comes into play. And a biopsy, our pathologist is that good that he can tell you whether or not someone has multifactorial hair loss, meaning they have one of these scarring hair losses and they have patterned hair thinning as well. So it's a little more complicated maybe than one might hope, but we have lots of good treatments.
Okay. Anyone else? Dr. Rabinovitz, do you have any comments? You're muted.
I think the most important, as has already been commented on, is the importance of doing a biopsy early. And again, it really just depends on what you see all the time. In general dermatology in the clinics, alopecia is quite common. For someone who specializes in skin cancers, it's not so common. So the individuals who do this every day are the best to handle. I think a big important factor now is the use of dermatoscopes has been a tremendous impact on evaluating these patients. And now with what's called fluorescent dermoscopy, that's just a different type of light which has been incorporated into the dermatoscopes. It really is paving the way for better understanding of these diseases.
Okay. Let's see, another question. Can minoxidil be helpful in scarring alopecia if caught early?
It's not going to address the inflammatory component, but it can certainly help the hairs regrow faster. So a lot of patients like to use minoxidil, so they know that whatever hairs that are struggling will perhaps become terminal hairs faster again, but it's not going to address any of the cicatricial inflammatory component. That's why it's important, I think, to make sure that you're not dealing with just patterned hair lossing when you have a cicatricial problem. Many people believe that anyone with any kind of hair loss should be on minoxidil because it can only help. But again, it's not going to get at the root problem with someone who has a cicatricial alopecia. So you would use it as an adjunct to therapy.
And can topicals potentially irritate, inflame the scalp further? And if so, how would you proceed?
Well, I will say that I wish minoxidil came in an oil because the alcohol base that it comes in can be drying, especially to some of our Black patients who find that their hair gets dried out more easily. So many people are using oral low-dose minoxidil to avoid having to use a topical agent that is alcohol-based because even the foam can be drying and irritating to the scalp. So that's something to take into consideration.
Okay. Well, I think it's if we could have the next slide, Kenza. These were great presentations, Dr. Jung and Christy. Certainly subjects that I don't know anything about. So I think they were very helpful. Thank you very much. And our next presentation will be on Monday, May 4th at 4 o'clock. Our speaker will be Dr. Renee Copeland, a PGY3 derm resident who has spoken with us before. And the case presenter will be, I'm butchering this name, Adora Tugoku. Is that approximately correct? Third-year medical student. And the the CME code is here on this slide and should be posted in the chat. And after the May presentation, we'll take a summer break and reconvene our TeleEchos in August or September. That's just a break for the TeleEcho sessions, not for the clinical arm at all. And another announcement is, so next month, the May presentation, Dr. Patton will be facilitating. I will not be able to attend. I am officially retiring from Augusta University on April 20th, but after a 4 or 6 week break, I will be returning part-time. So I will be back and continuing with my role in teledermatology, serving Georgia. When I made the decision to retire and come back, it was with the TeleDerm work would be, one of the big things that I would continue with, and that aspect of my position. So I'll be, I'm gone for a few weeks, and then I'll be coming back, and certainly back in the fall when we pick up the TeleEchos. So thank you to everyone for being here today, and I think that just if the TeleDerm Hub people can stay on for a few minutes, all of our guests can take off, and I won't see you, but everyone else will see you next month, hopefully. Again, thanks to Sally and Christy for the presentations.